Can you please start us off?
Sure. Do you want to share your screen, Atara, with our slideshow?
I think that the moderator, Josh, I think that you have to share that screen, that slideshow.
Oh, there it is. Okay, so the talk is called To Test or Not to Test, Grappling with BRCA. Some people might have heard of BRCA, but really the correct way to say it is BRCA, but I kind of don't always think about it, and I kind of just go between both. So sometimes I'll say BRCA, sometimes you'll hear me say BRCA. Sorry, I'm just figuring out how to move things along. So Atara already introduced all of us. So I am a genetic counselor for JScreen. We thought that today it would be interesting to kind of present all the information through two different scenarios or two different cases that I've seen as a genetic counselor. I've been doing cancer genetics for about 12 years, and I've seen a lot. I've worked in the Jewish community, especially in the Orthodox community, for a lot of the time. And unfortunately, I've seen a lot going on. So we thought that this first case would be really interesting to discuss. So this was a 37-year-old woman who presented to me. There was a free BRCA testing event in her shul, and it was testing people who had Ashkenazi Jewish ancestry or Eastern European or Central European ancestry. Her mother had been diagnosed with ovarian cancer. Sorry, her grandmother was diagnosed with ovarian cancer, but other than that grandmother, she didn't really know much about her family history. She herself is a mother of 3, and she is not planning on having any more children. But the issue was that she has a sister who's 28 years old who is still single, and she was nervous that, you know, if she were to get tested that would and be positive, she'd have to tell her sister, because this could be really important and useful information for her sister. But at the same time, she was nervous that if her sister finds out that she's also positive, that can, you know, hurt her, so to speak, in the shidduch realm. So there are a lot of different issues that come along with this story. My job here is to kind of give you the background as it relates to the genetics, and then I'm going to give the floor over to Melissa and Atara. So what is genetic about cancer? So most cases of cancer are actually not genetic. Most of them are sporadic. They happen by chance, or sometimes they're due to something environmental. But again, only a small piece of the puzzle, only a small percentage of cases of breast cancer especially are hereditary. They're running in families. However, some definitely are running in families. So the way that the image that I use to signify cancer is this blue little blob, which you'll see on the next slide as well. So again, most cases of breast cancer are actually not hereditary. They don't run in families. Most of them happen by chance, but some of them do run in families. And the reason that they're running in families is because there's something going on with the cancer genes in the people in that family. So to take a step back, we all have about 25 to 30,000 genes, and every gene in our body has an important job or important function. And we have hundreds of different genes that are called cancer genes, and their job is to protect our body from getting cancer. So it's really important that these genes are working properly because they're protecting us from getting cancer. So I like to show the cancer genes kind of like a shield or like a bodyguard. And every time a cancer cell, these blue little blobs, try to come into the body, the cancer genes say, nope, you can't come in, and they stop the body, or they stop those cancer cells from entering the body. However, if there's a problem with one of these genes, or what we like to call a mutation or a structural change in one of these genes, then the gene will not work properly. So here you can see that there's a mutation in this specific cancer gene, and that makes like a crack in the shield. And because there's that crack in the shield, those cancer genes could kind of like slide through and could enter the body. So in other words, anytime somebody has a mutation or a structural change in one of their cancer genes, that's going to increase their risk for getting cancer. Depending on which gene it is, it's going to be a different type of cancer or types of cancer and a different degree of risk. So one example that probably everybody here has heard of is the BRCA1 gene. There's a BRCA1 and a BRCA2 gene. We all have these genes. However, if there's a mutation in one of these genes, that's going to cause an increased risk for specifically female breast cancer and ovarian cancer, male breast cancer and prostate cancer, and pancreatic cancer in both males and females. So the biggie here is clearly the breast cancer and the ovarian cancer. Somebody who does not have a mutation in their BRCA1 gene has about a 13% chance of developing breast cancer. However, if they do have a mutation, that risk is up to 87%. Similarly, with ovarian cancer, not a very common cancer in females, about 2% of women who don't have a mutation will develop ovarian cancer. However, if they do have that mutation, their risk is, significantly increased. So what do we do when somebody tests positive? It tends to be, big news when somebody's positive, but at the same time, it could be very empowering to them. So if they don't already have cancer, but they find out that they have a mutation in this gene, there are two ways to think about it. So one thing that they can consider doing is increase cancer screening. So maybe starting their mammograms a little bit younger than a woman might typically start it, or maybe alternate between doing mammograms and breast MRIs or breast ultrasounds, or do them more frequently, or maybe do colonoscopies a little bit earlier and more frequently than somebody might do if they test positive for a colon cancer gene, etc. Or another thing they can consider doing, depending on what the result is they might do a surgery, like a risk reducing surgery. So for example, if a woman tests positive for a BRCA mutation, it would be recommended that she removes her ovaries to greatly reduce the risk of her developing ovarian cancer and also breast cancer. And there are some other examples depending on which type of cancer it is, but I'm focusing more today on the BRCA. If somebody already has a cancer diagnosis, it might help, knowing that they're positive might help them make some decisions about their surgery and their treatment. So they might use specific medications, they might do specific surgeries if they knew that they're positive for whatever gene it is. How genetics impact a family. So this is a big part of our little story here. Anytime somebody has a mutation in one of their cancer genes, each of their children and each of their siblings and parents too have a 50% chance of having that same mutation. Whether they're a son or a daughter, a brother or a sister, every first degree relative of somebody who has a mutation has a 50% chance of having that same mutation. So in our story here, if the woman tests positive, then her sister would have a 50% chance of being positive as well. You don't get to choose. It's spontaneous, either she has it or she doesn't. It's a 50-50 chance. One last thing that I wanted to mention before we move on is that having a mutation in a BRCA gene is much more common in people who are Ashkenazi Jewish. Generally speaking, the population risk is about 1 in 500. So about 1 in 500 people will have a mutation in one of their BRCA genes. However, if they're Ashkenazi Jewish, their risk is tenfold that. It's about 1 in 40. So 1 in 40 Ashkenazis will have a mutation in their BRCA gene, which is why they had that event that this woman was going to. And that is my part of the talk. Thank you.
And so before we move to Yoetzet Halacha Atara, I'm going to talk about some of the psychosocial or emotional issues around deciding to screen. So again, my name is Melissa Rosen. I am with Sharsheret. Sharsheret provides free psychosocial support to anyone who is impacted by breast cancer, ovarian cancer, or a higher diagnostic risk. And we provide culturally meaningful support within the Jewish community. So I think the first question we should address is, why would somebody want to screen, right? We see that this is a weighty issue. Can be a very difficult issue. In the case study that Esty presented at the beginning, the woman notes that she has 3 kids, she's done having children. So in theory, that may or may not be a deciding factor as to whether she screens. This is very different, and I know Esty's going to go into this, than prenatal screening. So whether or not she wants to have more children isn't necessarily a reason to screen or not to screen. Even with her family complete, and no longer there being a risk of her, if she tests positive, her passing it down to a child, it's important to know whether or not one carries the mutation for a few reasons. One is it allows a patient or a woman or a man to be very proactive about their health. And you'll hear us talk about this a lot. While learning one carries a mutation can be scary, it can just as equally be empowering, because there are many things, some of which Esty mentioned, that can be done to lower risk below even the average person. And if she does turn out to carry a mutation, it's important she know that, so then when the time is right, her children can be screened, because as Esty mentioned, 50% of the time she will pass that down to a child. Or with each maybe a better way to say that is, with each pregnancy, there's a 50% chance. So whether she tests positive or not, whether she decides to test or not, what shouldn't dictate that decision is what's going on with her 28-year-old sister. So one step at a time is a great way to take this. It's important for her to know, because there's a little bit of a family history and she's of Ashkenazi Jewish descent, whether she carries, and she has an interest, whether she carries a mutation. Whether she chooses to tell her family the results is the next step. Let's do this one step at a time. And in terms of sharing with the family, yes, it is a genetic mutation, and in the best case scenario, the results should be shared with a family. But there are a few things to keep in mind. One is, take some time to process the results yourself before you start sharing those results with somebody else. And it's not something that it's important information. So you need to find the right time and the right setting. That will be different for every family. For some, it's got to be a one-on-one private conversation. For others, there might be strength or chizuk from the family being around. And set a tone. Yes, again, this is scary, potentially scary things we're talking about, but knowledge is power. And so if indeed she does need to share the news that she carries a mutation with her family, she can set that tone by providing really empowering health messages. Family members may react poorly or even differently, may decide they don't even want to hear about it. So give them some time to digest as well. Decisions to screen or to act on the results of screening are not usually an emergency. Even if somebody does learn they carry a mutation, now it's different from a medical perspective for every person, but most often a person can plan their family, building their family, finish nursing, whatever it is, before a prophylactic or risk-reducing surgery is needed. And so that's really important to keep in mind. But these are deeply, deeply personal choices. Every situation is different and every decision is personal. What this woman can do is advocate that family members get screened, but she can't force it. Again, very deeply personal. With our work at Sharsheret, I've spoken to many families where some of the family has decided to screen and some of the family has decided not to screen, at least for now. But in this case, it's important to emphasize that by knowing, they can lower their risk, sometimes dramatically. And so that's a positive reason to do it. And she's not yet married. So fertility, to discuss the fact that that there are so many options today that there weren't even 5-10 years ago, where she could build a family without risk of passing it on to her children. And that's really important. And then the other thing is, just because somebody carries a mutation does not mean they will be diagnosed. Yes, it's an increased risk, but it's not a guarantee. And a reminder that even people who don't, as Esty said, carry a mutation can be diagnosed. And the last thing I want to say is, genetics is a difficult topic for a lot of us. We don't understand it necessarily unless we've been trained to understand it. And there are a lot of emotions that come along with this. So one of the things that is unique to Sharsheret is that we offer family conference calls. So if somebody is struggling to share with their family what the results were, either because there's too much emotion there, or there's just not an understanding, we have a genetic counselor on our team that sets up calls, conference calls or Zoom calls from family members all over literally the world, and they have the conversation together, guided by a genetic counselor. And the great part about working together with Esty is that J-Screen and Sharsheret are constantly referring back and forth to one another organizations. So, there's support available from both. And with that, I'd like to turn it over to Yoetzet Halacha Atara Siegel to talk about the halachic ramifications of this case study. You're muted.
Thank you so much. It's amazing to be in this conversation with these just amazing women. Josh, I'll take the slideshow in a minute. Not yet. Thanks. So I want to first talk a little bit about this holistic approach that we're doing. I actually specifically didn't start out explaining this relationship because I think that it's important to see it in action before we, in order to really understand it. In general, all of these decisions surrounding genetic testing, screening, decisions if somebody does find out that they have a genetic mutation, all of these decisions are not made in a vacuum. What you have here is somebody from the medical professional, SD, who's coming from the perspective of genetic screening, working in consultation with oncologists, general physicians, and you have Melissa Rosen, who's here from a supportive social organization who is providing family support, social support, community support. And it's important also to understand that all of these decisions obviously happen in the context of our religion, of our halachic system. And it's when somebody is asking these questions about their medical health, about their background, about their genetic profile, it's important to understand that all of these factors come together. I just actually worked with Melissa on literally a 20-hour, probably 20-plus hour training for a group of 40 Yoetzot Halacha that talked about issues surrounding breast, ovarian, other gynecological cancers from a myriad of perspectives. We had psychologists come on board. We had social workers come on board. We had oncologists on board. We had a reproductive health specialist come on board to help Yoetzot who are dealing often like one-on-one with women from a halachic perspective, often from a friend perspective, or from a religious support perspective, to understand like all of the different things that are going on. So if you are listening and this is something that actually affects you personally, I really wanted to encourage you to avail yourself. Understand it's Esty who's outstanding and amazing, who might talk about the medical issues, but it's important to avail yourself of Melissa's services and the people she works with at Sharsheret and the Yoetzot, the 40 plus Yoetzot who are trained in how to ask these questions, because there are a lot of halachic questions that come up as well. I'm going to right now choose a few. Like there are many halachic things that as Esty talked about this case, there are many things that came up. There are many halachic perspectives. I'm going to just focus on two of them and look at them from a very limited perspective. Obviously, each question could have its own 3-hour share, but I want to like highlight a few things that might come up. Of course, important to understand whenever we talk about halacha is that 2,000 years ago when the Gemara was being written, they weren't sitting around in Syria and Pumbedisa and Bavel and Babylonia and saying, well, when we are talking about PGD or we're talking about doing IVF, when we're talking about genetic, they didn't know these things, right? And one of the beauties, like to me, one of the most amazing things about our halachic system is its flexibility, is the fact that we have a concept called the da'at yachid, that we make sure that we always maintain the conversation, even the minority opinion, the da'at yachid, because sometimes 2,000 years later, that idea that was not relevant at all 2,000 years ago, somewhere in the Middle East, that idea is relevant when you're sitting in an office tower in some medical complex in Jerusalem, in New York, in Houston, right? In Memphis, you're able to pull this idea out and say, okay, how is that relevant to today? Also, a little bit of a trigger warning. We're going to be looking at a few highlights. We're going to be looking at Rav Moshe's tshuva, Rav Moshe Feinstein's tshuva, a few of them. And he wrote them. Obviously, he passed away. I remember his funeral as a young child. He passed away decades ago. He was working with very, very difficult medical knowledge. So it's important. And so we use some of his ideas as a basis for some of the things that I'm going to bring out. And it's important to understand and to realize that there's been incredible medical advances since then. So if Rav Moshe is talking about something that we might say that's not relevant to my life, or that's such an outdated perspective, understand how far we've come, but there are still principles that we could apply to the situations today. So Josh, if you could help us out and put that up, I'd like to look at a few things. So a really famous tshuva that Rav Moshe wrote that dealt with what really is often behind that question about that sister. What happens if somebody finds out that she or he has a genetic mutation and he's planning on getting married? Is that information that has to be shared, especially in a community where people don't necessarily meet themselves, in a community where people might be set up, which happens in a lot of the Jewish community. Then what happens if somebody is sitting on information about their genetic profile? Is that something that has to be shared? Is that something that could be shared? Maybe it's better not to know, because once you know, you have to share. And that's something that people struggle with when genetic testing first became available and until today. So Rav Moshe was talking about the tragic case of Tay-Sachs. What are you supposed to do if about testing for Tay-Sachs, which was a disease that was that if both parents are carriers, then 1 in 4 of the children is going to be affected, and it's a death sentence. It's a terrible, terrible thing. But there was a fear that people who might test might not be able to get married. So he talked about he talked about a lot of different types of cases. So in conversation, he had a conversation about the case of somebody who was told by doctors that this is not Tay-Sachs. This is a different case, but it came up in that conversation. Somebody who might have a condition that would prevent them from regular menstruation, and therefore they would not be able to have children. Is that something that has to be disclosed? So that is a principle of the disclosure of an uncertainty. The condition is an uncertainty. She may or may not be able to have children. And does that have to be disclosed? So he actually says that he brings the concept of being released from ketubah. When a couple is married, if the marriage dissolves, then a woman receives a financial compensation that's guaranteed in the ketubah. So the next time that you're at a wedding and somebody's droning on and on in Aramaic at the chuppah, reading the ketubah, and you're like, what are they talking about here? It's a lot of strange words. Really what it's saying is that these are the financial obligations that the husband must give to the wife, among other obligations. So if a marriage is dissolved and a wife is severely at fault for doing something terrible, then she doesn't get the money in the ketubah. So that's an indication of somebody doing something wrong. So in this case, b'hatam, and the reason is that b'shvil safek eino mum lipater min af miktubah. That in the case of a woman who has a potential, maybe something that could be in her medical history that might prevent her from having children, it doesn't have to be disclosed, says Rav Moshe. And even if it's the kind of thing that would not require her to lose the money promised in the ketubah, meaning she really has every right to get married, so he says, because it's something that's uncertain. So I want to think about this for a second, the idea of safek, of uncertainty. We do see in cases where there is a significant issue that will for sure cause problems, it's something that actually Rav Moshe says has to be revealed. Somebody with Tay-Sachs, we like the way that, not leaving aside the way that different organizations have chosen to deal with it, something like Tay-Sachs has to be dealt with. It is something that is terrible, it's something that is fatal, and it is certainty. But I think what he is saying, we all carry around with us things in our medical profile, things in our genetic structure that we either haven't tested for or there's no test for it. We don't know the way that many, many genes interact. So when we're dealing with something that is a safek, an uncertainty, every person has a safek in their background. So when somebody is tested for the BRCA gene, I think it's important to understand, as Melissa stressed, we are talking about something that is actionable. We are not talking about something that is a death sentence, God forbid. We are not talking about something that will prevent somebody from having children who are healthy, God forbid. There are many, many options that are actionable, how to deal with a BRCA gene. And because of that, it is not something that we should be concerned that affects a shidduch. By the way, just as a side note, that a survivable certainty also doesn't have to be disclosed. So it's actually the case of somebody who has Marfan's syndrome, which has health risks that come along with it. And that's a certainty. Somebody with a genetic profile for Marfan's does have Marfan's syndrome, but it is survivable. I know several people who have wonderful, fulfilling, loving lives who are they get married, have kids, and they have Marfan syndrome. It's something that they have to be managed, but it's something that it's survivable certainty. So we're also not particularly concerned. Obviously, it's important when getting married. I want to just circle this back together. When people are building a relationship, honesty is crucial. So I'm not advocating for hiding things in your genetic profile. I'm advocating for discussing things in your genetic profile and talking about ways, thank God we're living in a time when so many things can be managed. So I think it's important to be aware and also to be aware of actionable, as Melissa always says, it's actionable. Be aware of things that we could do to mitigate risk and to have treatment. So it's important to look at there. In terms of disclosing to in terms of disclosing also to family, that really is when Rav Moshe talks about the idea of, Josh, if I could do the next slide. When we talk about the requirement to disclose of disclosing to family, it's really talking about dating and disclosure. It's not really talking about the idea of disclosing to one's siblings, as kind of Melissa really talked about. Esty indicated that you could tell a sibling, you cannot tell a sibling. Just because somebody is tested, it does not mean that they have to know. Of course, if you love your siblings and it's something that would benefit them, it's important to know. It's important to make sure that people have all the information about health. When we talk about something being actionable, one of the most significant actions that people take when they know that they have a BRCA gene risk is prophylactic surgery. So even though that's not really the conversation, that's not the topic of this talk, we're talking about whether or not to test. I think that every time we ask that question, whether or not to test, the second question is, well, what are you going to do about it, right? Because if there's nothing to do, if there's something that's not actionable, if somebody has a pregnancy and is thinking of doing testing on the fetus, when people ask me that question, I always ask two questions. The first is there something to be done that if the fetus does have something that's medically problematic, if there's something to be done that could save the child's life, make the child's life better, of course we have to test, I think. I'm not giving a halachic psak, but it's important to try to improve health as much as possible. But the second question is that if there's nothing to be done, then it's really an issue of your mental health. Like what is important? So in terms of prophylactic, in terms of the BRCA gene, that's not what the conversation is about now, but there are, if somebody is at a high risk for ovarian, breast cancer, or other cancers, a lot of times the risk can be mitigated through prophylactic surgery, removing a woman's ovaries and often their fallopian tubes, removing a woman's breast, sometimes one, sometimes the other, sometimes both at different ages. So I'd like to, for a second, somebody who says, wait, that might be what could happen. I'd like to take a second to talk about the halachic aspects around prophylactic surgery, because I think that makes it a little less scary, a little less big. So a very common thing people talk about is serous. Isn't that going to be serous is sterilization? How we know it says in the Torah many times that we can take away a person's reproductive abilities. So of course, to save a life, we can. And specifically, d'Rabbanan, according to the rabbis, sterilization of a woman is much less problematic. It's a d'Rabbanan, it's not a d'Oraita. It's a rabbinic law, not a Torah law, which means that it's very, very important and for saving a life. So it's much less of an issue. Danger of surgery, right? It's a difficult, surgery could be challenging. Surgery, anytime somebody has anesthesia, it always comes with a risk. Thank God we're living at a time when these surgeries come with minimal risk and tremendous reward in terms of saving life. Some people talk about chavala. We know that we're not allowed to harm our body, but of course we can harm our body when it comes to saving our life. Inducing anxiety. So I'd like to talk about the anxiety for a second. So I didn't bring them, but there are many tshuvot that talk about testing in terms of anxiety. We didn't really talk about when testing is appropriate. I'll talk about that in a little bit. But one of the questions surrounding testing is anxiety. Again, it's important to test at a time when people could take action. So for example, if somebody, generally, we try to take action if somebody has cancer in their family and they have a BRCA gene, then we try to make sure that that the surgery happens, there are many different factors. But let's say one of the factors is going to be years before, or the testing even happens years before, I think 5 years, but don't quote me on it, when the diagnosis was developed in the family, or perhaps by age 25, perhaps younger, but there's a lot of different things out there. Of course, it's important to test before the recommended age for having surgery, right? So it's important to have that information, not at age 40, because some surgeries are recommended at age 35. Some are recommended between 35 and 40, could be even 30. It's important to have the BRCA testing beforehand. But if somebody is 18 years old and is leaving high school, and he is not going to be taking action right now, and knowing that she or he has a BRCA gene causes a lot of anxiety, maybe that's not the right time to test. On the other hand, if somebody is getting married at 20 and is planning on having children right away, then it's important to test beforehand, before they got married at age 20, at 19 or 18, because then they could take action if they wanted to make sure that any future children that they have don't have the gene. So halachically, it's important to understand that anxiety, mental health, has a role to play here also. And of course, we have to always think about chaye sha'a, the life at the moment, but a potential small risk in the moment versus a long-term risk. And every day we make those, we do that risk benefit, the risk benefit shikul, a thought process about taking some short-term risks in terms of the long-term. So Josh, if you could forward, please. So just a few sources I want to bring up, that in terms of sirus nashim, which is sterilization of a woman, often if a woman's ovaries and fallopian tubes are removed, it's going to be after she's had children, like we had in Esti's case that she gave. It's a woman who's had 3 children and then she's done. So generally, we try to encourage a woman to either work on preserving fertility by having her eggs harvested and frozen, or to wait until she's done having children, depending on how long that's going to be. So in the case of a woman who chooses not to have children, someone who's had history, this is a case the Yamshel Shlomo talks about. If a woman has pain from childbirth, or if she's had children and she sees that her children are not going in the right path. I think that's a fascinating comment. I'm going to leave it on the side what that exactly means, to be scared that you might have more children who are not following the right path. I think maybe also there are lots of things that could be done. She has permission to not have children anymore. That's basically, this Yamshel Shlomo is telling us that that beyond other factors people might have in not having children, right, for whatever reasons that people can halachically limit their family size, one of them is that she's scared about something that might happen with the child, the health of the child. So people are allowed to choose not to have children. And Shut B'nei Banim by Rav Henkin Alav Hashalom says that even a person who has a real significant fear that about the health of her children, even if she doesn't have any, it's possible that even for a person who's never had children, like we always talk about people finishing having children and then they might have surgery, it's important to know that even somebody who has never had children is allowed also to not have children, even though we have this concept of having kids is so important. I would like to, at this point, hand it back over to Esti for our second scenario.
Esti, before you start the second scenario, can I add one more thing? I realize in listening to this very wonderful, bits of information from all different perspectives, that one thing got lost. So we talk about this being these types of mutations being actionable mutations, and that is true. But the only thing we've really focused on this evening is prophylactic surgery. But I just want to be clear that if someone learns they carry a BRCA mutation, there are many things they can do instead of prophylactic surgery or prior to prophylactic surgery that also A, reduce risk, and B, catch a diagnosis early when it's much more treatable. And that includes changing the process of screening, starting it earlier, doing it more frequently, having having different modalities. It includes healthy living, which truly reduces risk, whether one carries a mutation or not. For some, it might be taking a drug like tamoxifen before a diagnosis to reduce. So it's not just surgery we're talking about. There are a lot of really positive things that can be done. And I wanted to say that so that it didn't sound quite as scary. Thank you, Esty, for giving me that second. Please start with the second scenario.
Yeah, thank you. I appreciate that. So I did mention it before, but I think like a lot of the emphasis ended up being on the surgery.
Yeah.
For some of these cancers, there isn't even a surgery that's necessary. So yeah, definitely increased screening or more enhanced screening would be a great option for many people who test positive. Okay, so on to scenario 2. I know that we had a couple of questions in the chat. I hope to address all of those questions in this scenario. So I had a guy come to me. He's Ashkenazi. He's 25 years old, and he is engaged to a woman. And they're thinking about, maybe one day starting to have a family. So he came through JScreen and he found out that he carries 2 different things. He carries a mutation in the CHEK2 gene and also in the Tay-Sachs gene. And then his wife did 23andMe around the same time that he did, and nothing came up on her results report. So this scenario is like chock full of stuff. So I'll try to just say whatever I can about it, and then I'll, give the floor over to Melissa and Atara. So the first thing, sorry, just moving forward. Okay, so a little bit more about cancer genetics that I didn't mention before because I was kind of saving it for this one. Josh, can we move forward? There we are. Okay, so I mentioned before that most breast cancers are not genetic, and most of them happen by chance or they happen due to something environmental. And we did focus a lot. I don't know why this is moving around so much. Josh, I'll just press it myself. Okay. But when we kind of like zoom in on those genetic forms of breast cancer, most cases of genetic breast cancers or hereditary breast cancers are caused by mutations in the BRCA1 and the BRCA2 gene. But those are not the only genes that are associated with breast cancer risk. So yes, they do account for a majority of hereditary breast and ovarian cancer, but there are other genes, which are all listed here, that are also associated with breast cancer. So I mentioned in this story that this guy tested positive for a CHEK2 mutation. People who are positive for CHEK2, females specifically, have an increased risk for breast cancer as well. And both males and females who have a mutation are at increased risk for colon cancer. And each one of these genes might have, slightly different variations in which cancer types besides for breast cancer are associated with it. But this particular guy tested positive for CHEK2. Another thing that I wanted to mention is that it's not just breast cancer. And we kind of hinted to this before. There are many different cancer susceptibility genes. Today, we're focusing on BRCA and breast cancer, but some of the other genes have nothing to do with breast cancer. They have nothing to do with ovarian cancer. There are genes that have to do with uterine cancer and colorectal cancer, stomach cancer, leukemia, lymphoma, pancreatic cancer. So even though today the focus is on BRCA and breast and ovarian cancer, there are many other genes that have to do with other types of cancer. And I just wanted to put that out there. So if you have a family history of something that's not breast or ovarian cancer, this still might be, good information and helpful information to you. So who should test? So historically, we really only used to test people for cancer genes if they themselves had a history or if there was a pretty significant family history where a lot of people on the same side of the family had similar types of cancer over and over, or maybe cancer at a younger age. And the reason that we were a little bit, picky with who to test was really just because it was really expensive to do the testing, and every single gene cost a lot of money. Insurance coverage was very complex, and very often people were denied coverage, and it was a big deal for somebody to get tested. Nowadays, the technology that we have for testing is much, much better and much more affordable. And we believe, or I believe at JScreen, that really anybody who wants this information, anybody who wants to know whether or not they have a genetic risk to develop cancer, could get tested, and it's very accessible and very easy to get tested. So my belief is if you want the information, go ahead. As long as you're 18 or older, would be a good idea. But if you want the information, I would say go ahead. Even if you don't have a family history, even if you're only Ashkenazi and you think that's enough of a reason to get tested, I would say go for it. As you know, there are risks to knowing, and we discussed the anxiety that can come along with it and all these ethical, halachic issues that come along with it. But if you're okay with all of those, I would say, and you want that information, go for it, because as Melissa said, knowledge is power, and it could be really empowering to know that you're positive. not all genetic testing is the same. So I mentioned in the story that this guy got tested and was positive for CHEK2, and he was also positive for Tay-Sachs. So at JScreen, we are testing for 2 different types of genetic or 2 different categories of genetic diseases. So our first test, or our original test that we were doing at JScreen, is called our ReproGen test. And our newer test that we started about 1.5 years ago is this Cancer Gen test, the cancer testing that we've been talking about up until now. So a little information about both of those panels. First of all, they are 2 totally separate panels. So when you go to the JScreen website, you choose one or the other, or you could choose to do both, but all the results don't come out on one report. So either you get your reproductive carrier screening results or your cancer results, or you get both, but you're not getting everything all at once on one report. So you pick and choose which one is appropriate for you and which information you want. Our Cancer Gen panel is testing for 63 different cancer predisposition genes, including obviously BRCA and CHEK2. Anybody who's age 21 or older could do the test, whether they're male, female, Ashkenazi, not Jewish at all, doesn't make a difference, but they do have to be in the US. Our ReproGen panel tests for 225 genes, so it's a lot more robust in that sense. And this panel is to be used for reproductive purposes. So I know Atara spoke about Tay-Sachs in the beginning of our conversation with that famous Rav Moshe Tshuva, but basically these conditions that we're talking about are testing people to see if they're a carrier for a recessive condition, where if the mother and the father are both carriers for the same condition, they are not at risk themselves to have the condition, but their children would be at a 25% risk to have the condition. This kind of testing has been around since the 70s and 80s. It started out with Tay-Sachs testing, but as you can see, we've come a very long way since then, and now we're testing for over 200 different conditions. This test is appropriate for really anybody of reproductive age who's planning to have a child, whether it's their first child or whether they're adding to their family. Anybody who's planning to have a child should consider doing their reproductive carrier screening. The JScreen process is very, very simple. All you have to do is go to our website, jscreen.org, give us some of your information. We are going to ask you for your doctor's information because we do require, or state law requires, that a doctor signs off on all genetic testing orders. So we will coordinate that with your doctor. Once we get that test order, we will send you a spit kit in the mail. You'll spit into the tube, send it back to the lab. The results usually take about 3 weeks from then. We at JScreen find out what the results are. We let you know that the results are in, and then we will schedule you for a genetic counseling session with either myself or one of our other counselors. And you would have the option of either doing that session by phone or by Zoom. If there's a positive result, or if there's a carrier couple for Tay-Sachs or anything in between, we will definitely get in touch with your personal healthcare provider, the person who ordered the test for you, just so that we can, send them the appropriate information and help them, guide you towards somebody who's local to you, because we serve people around the country and we don't know every single specialist everywhere in the country. So we rely on the doctors to kind of help us, with the referrals, but we'll educate them about what the results mean so that they could appropriately refer you to the right people. Here's the pricing for all of our tests. You can find all of this on our website. We do have a really nice partnership with Sharsheret, as Melissa mentioned before. With the coupon code Sharsheret100, you can get $100 taken off any of these options, whatever you decide to do, whether it's the cancer test only, the repro test only, or both. This coupon code at checkout will take off $100 from the total cost. One last thing that I wanted to mention, I did mention that the wife of this guy did 23andMe. I'm sure everybody here has heard of it. You might have even seen like a kiosk at Target or Costco for 23andMe. 23andMe is a great test for recreational genetics. So it's a great test if you want to know your ancestry, if you want to know whether you have a genetic predisposition to be right-handed versus left-handed, which you probably should know by now. If you have a genetic predisposition to flush easily, if you drink alcohol, or if you can't stand the taste of cilantro, or if you like it, like the fun kind of stuff, 23andMe is a hoot. It's great. It's really fun to do. However, the caution tape is up for the health-related things. So they also have a health-related section of their testing where they will test people for a couple of these recessive conditions like Tay-Sachs, and also for BRCA, not any other cancer gene, just BRCA. I do want to warn you that this health-related portion of their testing is not good. I would not recommend that anybody does that and that only for their health-related genetic testing. They test for much fewer conditions and fewer genes. The technology that they're using is very old school, so it's not very accurate. They're missing a lot of carriers. They don't have genetic counseling services, so they don't have people to help people through the results and explain what they mean and send them to the right people. So go for it when it comes to finding out your ancestry, but please do not use any direct-to-consumer companies like 23andMe to find out whether you're a BRCA carrier or a Tay-Sachs carrier. Please come to JScreen or visit a local genetic counselor who can get you through those results in a very medically appropriate way. And one more thing that somebody asked about in the chat, one more option for family planning. If somebody does find out that they're positive and they want to make sure that they don't pass it along to their future children. So this can apply if you already have children, but if you're planning to have a child and you find out that you're positive, whether it's BRCA or CHEK2, or if you're a Tay-Sachs carrier couple, there are options for people in the realm of family planning. The first option Atara spoke about before, it's called in vitro fertilization with pre-implantation genetic testing, where you go through an IVF cycle and create an embryo outside of the body. But before implanting that embryo into the woman's uterus, they can do genetic testing on it. If they see that the embryo did, in fact, inherit that mutation, they'll discard it in the lab. It will never become a baby. But if they see that the embryo did not inherit the mutation, they're going to implant it, and hopefully it will lead to a successful pregnancy. It's going to be a child who does not have that mutation. Tomorrow night, there's a great talk by Dr. Sahar Wertheimer, who I work with a lot. She's a wonderful REI specialist in the LA area, and she has a whole talk about this with another Yoetzet whose name I forgot. I'm sorry, but I know Sahar is wonderful, so I definitely would recommend that you tune into that lecture. But some other options might be to use a gamete donor, meaning an egg donor or a sperm donor who's not a carrier. Some people might decide to test the baby during a pregnancy to see whether or not it's been affected. Some people might decide to adopt. The point is that if somebody finds out that they're positive and they want to do whatever they possibly can to ensure that they're not passing it along to a future child, there are options for them, and a genetic counselor can help with those. And I believe that's the end of my portion of this.
Okay.
Yeah.
So, like the last, thank you so much, Esty. Like the last case study, this one has quite a few psychosocial or emotional issues, because the reality is that cancer, or the possibility of a cancer diagnosis, raises difficult emotions in all of us. So let's start with the first part of it, where the husband was, through JScreen, learned he carried a CHEK2 mutation as well as a Tay-Sachs mutation. The wife happened to go through 23andMe and nothing came up. Okay. Whether or not to retest the wife with a medical grade test, as Esty said, she would clearly suggest that, particularly in the case of a Tay-Sachs mutation, because we already know that one spouse has it, and it's such a catastrophic diagnosis that it makes sense to confirm that the wife no longer has it. I do want to point out that 23andMe and all of these direct-to-consumer tests are very clear on their paperwork or whatever it is, that any results need to be confirmed by a medical grade test. So it makes sense with such a non-invasive procedure for the wife to get tested again to ensure, primarily at the moment, that she does not carry a Tay-Sachs mutation, but also with regard to cancer genetics. Another interesting thing that we may not think about is that it's the husband that's carrying the CHEK2 one here. So I know we've all alluded to it. I just want to be really clear. BRCA mutations, CHEK2, PALB2, any of these others. Okay, so men and women carry BRCA mutations in equal numbers and pass those mutations down to male and female children in equal numbers. Now, as someone who has spoken about these topics for many, many years at this point, I can tell you that I can say that over and over again, and somehow some people cannot process that. You know what? I get it. BRCA has been touted as the breast cancer gene, and we associate it with breast and ovarian cancer, and we associate those cancers, rightly so, with women. I also want to be clear, once again, to reemphasize what Esty said. It's not just breast and ovarian cancer. There are some that are just male cancers there. BRCA raises the risk of prostate cancer. It raises the risk of male breast cancer. Plus there's pancreatic and melanoma. But because these mutations for so long in the public eye have been associated with women, there is a discomfort that might arise in a man who carries one of these mutations. I would say that the best thing to do in this case is educate yourself about how these mutations impact men just as much as they impact women. And in doing so, you'll probably find yourself so passionate about it that you'll be sharing that information and perhaps saving someone else's life, which is really lovely. But it's okay to feel that sort of dissonance, that discomfort, because it's different than what's out there in the general population. It's just not thought-wise, it's just not factually true. So it may take a while to get used to that. And then the last emotional issue that I want to discuss with regard to this case study in particular is a change in assumptions about how one builds a family. Carrying a BRCA or similar mutation does not mean that someone will not have a family. There are lots of ways to build a family, including the regular way, which plenty of people who carry these mutations do. But as Esty's last slide pointed out, there's PGD, or there's adoption, or there's gamete donation, or all of these other options. I do want to say that although it's absolutely amazing that we have these options available to us now, I mean, beautiful and wonderful, it's perfectly normal to grieve your expectations. And in the end, God willing, there will be a beautiful family, a beautiful home filled with healthy children. But until you get there, it's okay to grieve what you assumed your next few years or the next stage of your life would look like. That's completely normal. And one of the things Sharsheret offers is a wonderful team of social workers that can help in all of these things, whether it's anxiety regarding a diagnosis, questions about how to talk to children, issues about living with a genetic mutation, or fertility concerns surrounding a cancer diagnosis or a mutation diagnosis. All of that is available to anyone who's been diagnosed, who hasn't been diagnosed, who's concerned, who knows they carry mutation or isn't sure yet. All you need to do is call, and we are there, and it's free and confidential and completely individualized, because cancer isn't just a physical diagnosis. It's emotional, it's spiritual, as Atara talks about, and it's so important to address all of those concerns. And part of that is knowing the halakha and seeing how it impacts your personal situation. So with that, I turn it back to Atara.
Thank you so much. That's such great information. I wanted to stress before I start my little piece that there are so many halachic issues that come up. I'm just going to pinpoint a few. And they're obviously not reflective of all the many things that come up. Meaning each of the things that Esty and Melissa said, each line could be its own share. I also wanted to, before we end in about 5 minutes, I wanted to invite anybody to put a question into the chat, because I'll talk for about 3 or 4 minutes, and then we'll leave the last 2 minutes for questions if people have. I also wanted, so maybe Josh, we could start the slideshow. that Esty talked about is she referenced that Rav Moshe Tshuva that I referenced earlier. I have it here. In general, when the testing, as Esty talked about, this technology has been around for decades, and when it first came out, there was tremendous hesitation. At the time, the question was: is it permissible to test? Are you allowed to test? And Rav Moshe was really a pioneer in this, and we keep on going back to him, even though, of course, there's been dozens and dozens of tshuvo written in the decades since. And he was the one who really opened it up and said, you can test. And that was it was a huge window to open up that people could walk through. And I bring this little line of the tshuva that because I think it's important to understand that if social constraints are an impediment to testing, it doesn't mean that we don't test. It means that we try to understand what those social and religious constraints are. What are those anxieties? These things come up in halacha, in mental health, in what's going on in a person's community. And the answer isn't to say we don't test. The answer is to say we test, but with wisdom, with insight into what's going on. So if there's going to be concern about a shidduch issue, then we're private about it. Maybe we don't, broadcast it on our Facebook profile, but it's if somebody has, as Esty talked about, those 225, I believe, recessive genes. If somebody tests positive, doesn't mean, God forbid, they can't get married. Doesn't mean that it means that they have a conversation with their potential spouse and they talk about it privately. Maybe not on a first date, but there's a time and a place to make sure that these things are caught. And just for the rabbinic perspective, I brought a quote from Rabbi Mordechai Willig, Rosh Hashiva at YU, who says that he strongly recommends from the medical perspective that any woman who is recommended by a physician based on the family history to be tested should do so, and should do so right away. I read that from the slide because I think it's important. I like how he said right away. Again, I think the right away does not mean like today, but I think it means at the appropriate time while one can do something about it. It's important to make sure that a person gets the testing done when they're recommended. And as Esty said, at this point, really most people, for everybody, it is recommended to get tested for recessive genes because there's so much that we could do about it. Esty also referred to the conversation tomorrow night with Sahar, she's excellent. She's so smart, and she has a great way of putting things. And Yosef Alacha, Lori Novik. I cannot recommend enough to be able to go to that session, because if you're interested in these questions, Laurie is the brains behind the Deracha website. If you've used it, and if you haven't, and you love Jewish learning, you should use it. And she's going to talk about a lot of these issues. I would like to, in case you're not going to, I'd like to talk a little bit about one example. So there are many. We talked about the gamete donation. We talked about adoption. We talked about all the different things. So for a second, we'll talk about PGTM. And the general halacha consensus is that, of course, it's crucial to do. Right now. I'm talking about the BRCA gene. That it's important to have the option of looking into these other technologies. I'm sorry, this is not about BRCA. This is about, in general, let's say a child who has, if a couple has a recessive gene. I'm just going back to Tay-Sachs because we're familiar with it, but there are many other things that might be very lethal. Rav Yaakov Ariel says that if the chances are high that if a child is going to be born sick, very sick, then the couple should not have children the natural way. On the other hand, Rav Nevin Saul talks about if the manifestation of the disease is later, then we act according to the medicine of the current time. It's important to understand what's going on, the different things that could happen. For example, with BRCA, if somebody a couple might choose to have PGTM, to do PGTM and IVF in order to make sure if they have a family history of cancer that's been so challenging. And I might say, I never want to have my child have to go through the challenges of these cancers. On the other hand, and there might be a couple who is struggling with fertility and they might attempt a few rounds. It might be financially out of their league. We know that the BRCA gene is something that is actionable. They don't have to do BGTM. It might take a toll on their relationship. It might take a toll into their religious life or their intimate life, their emotional life. They don't have to do it as well. It's something like that it's important to have a conversation with their medical professional, with their halachic professional, with their social mental health professional. It is interesting, I just, as a little kind of Rav Dov Lior, who's a little bit extreme on these things, I just want to say there is a perspective that says, trust Hashem, when we're dealing not with something that, God forbid, a child will die in a few years, but we're dealing with things from decades to come. There are those who are, we'll deal with it when it comes. If that's your perspective, there's also a valid halachic perspective there. I would always just encourage people, and Josh, I think we could be done with the slideshow. I think it's important to understand that there is no one-size-fits-all answer from a halachic perspective or from a social or medical perspective. It's important to look into every situation as a case-by-case issue. So I think with that, we're at the end of our time. Thank you all so much for coming. In our bios are ways to contact us. If you have questions for either SD, Melissa, or myself, please feel free to reach out and ask us questions. Thank you for coming, and we hope you have a good night or a good morning if you're in Israel like I am.